I've got a lot of content in this presentation. I've just come back from 6 weeks holidays, so I'm going to flip very quickly through a lot of it. You can view it as resources. I'm really happy to be contacted later to talk over specific details, if you like. I just want to acknowledge the physiotherapists that have gone before me in paving the way for physiotherapy interventions in treating children with lower urinary tract dysfunctions. We're very lucky to have Janet Chase and Wendy Bauer, who are both Australian physios who've sat on the ICCS board for many years and have contributed towards the development of guidelines and treatments for children. We've got a long way to go to understand some of our interventions and do research, but it's really nice to have a start there. As a physiotherapist, we sit within a multidisciplinary team, ideally when we're treating children, and neurotherapy is the primary treatment, which we've discussed. If you add relaxed voiding and optimal toilet posture to your standard urotherapy, then the research shows that most centres get very good results, 75 to 95%, just with that approach. To be a good urotherapist, which we all are, it doesn't matter whether we're physios or doctors, we're all urotherapists. You need, though, to be successful to understand the physical, cognitive, behavioural development and comorbidities of the child and adolescent that you're working with and work around that, because often it's those things that stop the child actually completing or being compliant with the program that we want. Environmental factors are really important, whether they're physically or cognitively able to do the program needs consideration. One of the really common things that we see are kids that don't have easy access to a toilet, and that completely messes your program. So we write to schools all the time requesting easy access to a toilet for a child who's trying to drink well, doesn't want to hold on, but the teacher won't let them go out. And teachers are great. If they understand the child's got a bladder condition, they're really supportive. That gives the child confidence, and then you actually gain success, and it's a really common thing. And our overall philosophy and mine is that the program has to be individualised. We don't do banks of treatment. It's an individual program, and it's respectful, non-invasive, to reflect the child and family's preferences, learning styles and cultural beliefs. Physios specifically will bring to the clinic a posture and body awareness to improve voiding and defecation. We work on retraining muscle patterns and coordination, and teaching relaxed voiding is just bread and butter stuff. If you set up the environment properly and assess individually, give a child an opportunity to do something properly, then you see muscle patterning changing, and we see an improvement in the voiding and defecation patterns. Some children need specific pelvic floor training, often they don't. It's more around relaxed voiding, behavioural modification. Some children need, and the older ones might need education on pelvic floor safe posture and exercise. The evidence also is growing around the use of adjunctive neuromodulation for children with overactive bladder and proven slow transit constipation, and we're using that in the clinic. All our interventions need outcomes. These are the outcomes we look for, resolution of signs and symptoms. If you just think about a child who has overactive bladder, and it's really common in kids, what's happening to their pelvic floor and to their muscles? Well, the pelvic floor is contracting to counteract the bladder, and a pelvic floor muscle contraction will counteract an overactive bladder, and this is what kids do. They spend their lives holding on, trying to avoid leakage and postpone going to the toilet. The end result of that is a non-relaxing pelvic floor and often dysfunctional voiding. Overactive bladder and dysfunctional voiding go hand in hand. We see it commonly together. What we want is a pelvic floor to relax completely to allow bladder and bowel emptying. There's a subgroup of children with detrusor underactivity that we see that totally don't hear any of their messages. They have large bladders, and if you look at them or assess them, they void with abdominal strain. They're a very specialised, tricky group of children to treat. And always remember that constipation will cause pelvic floor dysfunction. So when we're thinking about what interventions are appropriate, Do we want pelvic floor exercises for a child who's constipated? Clearly not. You treat the constipation, give the child an opportunity to normalise parameters, and often you find the pelvic floor settles down consequently. So if you understand muscles and the interaction between muscles, you can actually treat and apply some of the clinical knowledge that we know, and there's a lot of research around how muscles work. And really a lot of what I'm doing is applying clinical knowledge to the child that I'm seeing. It's really important, I think, with working with children to know that getting it all together is integrating it. It's a learning process in children, and you have to think globally. You can't just look at the pelvis and the muscles. So relaxed voiding is a regular thing. You want to allow a correct posture for correct muscle patterning, down-train your global system. I focus on abdominals. If you relax your abdominals, your pelvic floor will relax for you, and it's easy for a child to learn abdominal relaxation. Ensure good posture. Give the child an opportunity to practice the correct technique. Often, function becomes innate, and we see parameters normalise. So good toilet posture. This is a Uroflow of a 6-year-old girl with daytime wetting who was in the WATCH study. The Uroflow obviously is grossly abnormal. She's got a poor flow rate, a long voiding time, and large post-void residuals. So the only intervention she had was timed voiding in the WATCH trial. The first Uroflow was at the beginning of the trial. The second was at 3 months. And she came to clinic at that time. We assessed her and I taught her some relaxed voiding. And she did that. A hugely improved, very simple intervention. I just taught her, I corrected her toilet posture, taught her some abdominal relaxation, and told her to listen to her wee. It should sound like a s. And her parameters are starting to change. She's still got a large post-void residual, so I added double voiding to her program, and we will watch her, and hopefully over time we will see an improvement in her Uroflow, an improvement in her voiding efficacy and bladder emptying, and a resolution of her signs and symptoms. Really simple stuff, but it's very, very effective. You just need to take the time to and make sure that the child can start to actually do the right thing and set up the environment so they can do it regularly. There's lots of challenges in assessing pelvic floor muscles in children. We don't know anything about it. It's nothing in the literature. We've learned lots. We have a long way to go about understanding. We can apply what we know from adults and cut and paste to kids, but we're working with developing bodies and brains. Our tools have some limitations, and we still need to do a lot more work in really understanding and defining the dysfunction. Biofeedback's a really useful tool to change motor learning. It helps you identify dysfunction, teach correct action, train for your prescribed muscle requirement, and then incorporate into function. And there are a number of tools that are used in a lot of different clinics. My preference is always for non-invasive approaches that cause no collateral damage. So I will use auditory and verbal and visual and tactile techniques. I love the real-time ultrasound. Pelvic ultrasound is fantastic. It's non-invasive. I'm not a big fan of surface EMG and manometry we're not using. You can't talk about how to do pelvic floor exercises and expect someone to do it. Or you end up with the case of the 12-year-old boy who in clinic had no idea where his pelvic floor was. So the registrar and I gave him a bit of education. Yeah, they squeeze and lift, that's what the muscles do, blah, blah, blah. And he thought he understood the muscles, and he'd go and try exercising them. There was a busy clinic, didn't have time to assess him properly. He came back to the next consultation, absolutely no change in his continence, but the only thing he'd done was his pelvic floor exercises. He was doing them 20 times a day, which is what the reg was saying, and what he was doing was manually squeezing and lifting his scrotum 20 times a day. So you just can't talk about it and expect anyone to take anything on board. They always get it wrong. So a lot of clinics use biofeedback. In the literature, there's a lot of talk about biofeedback. It's a bit confusing because it incorporates a whole lot of different treatments and approaches. This recent systematic review and meta-analysis done to Cochrane recommendations, I was really pleased to find it because it kind of supports what I feel clinically and see. They found no evidence that biofeedback is of use in non-neuropathic voiding disorders in children. It's become very popular in a lot of centres, and it may be of use in some children with specific dysfunctions, but we need to actually improve and understand and define the dysfunctions that may be of use. Basically, the author could only include 5 RCTs of good quality in the review, and each of those studies, the studies were different. 2 of them involved clinics that use real-time Euroflow, where the child sits on a Euroflow and watches the void and tries to change the parameter of the void. And 2 of these studies were surface EMG, perineal EMGs with a light, and the hope is to change muscle function, and 1 was surface EMGs, perineal EMGs, and computer games. Interestingly, the editorial on this was asking for the ICCS to actually better define the dysfunctions that biofeedback might be of use for, rather than doing more trials with biofeedback. They also questioned the cost and the quality of life issues in these battery of programs. My stand is, and my experience is, if you really understand children and muscles, you can actually do a lot without banks of biofeedback treatment. There's a Dutch protocol that's been published on an RCT that's underway that the Dutch pelvic physios are doing, looking at the effect of pelvic physio versus standard medical care on children with functional constipation at the moment. They're looking at a whole lot of interventions. It's quite interesting, and it'd be very interesting to see their results. It might help give us a bit more understanding about things. Pelvic floor muscle training, though, can be of use in specific situations. It can improve cortical awareness and coordination, and you can improve voiding efficacy and coordination with abdominals and defecation. Some kids need it for bladder and rectal sensation. There are some subgroups of children that actually need to strengthen. I'm seeing a fairly large number of children that may need just a 1 or 2 consults who are deconditioned for a whole range of reasons, adolescent children who then develop secondary incontinence. You need to assess them completely. It's not always about their pelvic floor. Some of them, though, are deconditioned, have stopped moving and have lost timing and need to have things rebalanced. Children with cystic fibrosis are a very specific subset of children as well, that we know girls with cystic fibrosis do have stress incontinence. Stress incontinence is considered fairly rare in children, but this subgroup of children do have it. At the hospital here, our physio teams that work with these children offer an early intervention to screen them. They offer education around urotherapy, pelvic floor exercises and protection, and they're very careful to teach the girls airway clearance techniques, which is very important for their health, in pelvic floor posture-friendly positions. So the key tool I use is pelvic ultrasound, which we've already talked about. It's just great. The parents and kids love it. It tells you a lot. It's real time. It's a snapshot in time. This is what we're seeing now, and this is helping me understand what to do with the child. I use it to assess pelvic floor muscles as non-invasively, and what you're looking at for is an effective lift of the bladder base during a contraction. So it's used for rectal distension, and let's see if this works. This is a bladder, so it's a transabdominal, there we go. So that's a correct pelvic floor contraction. It's a quick flick, and I think you can all, well, let's find it again. Where's it gone? Do you want to try your own? So you watch it and you squeeze and lift. Physios know this stuff. It's visual, it's non-invasive, it's real-time ultrasound. We're not assessing the pelvic floor directly, we're looking at the lift component against a bladder. And real-time ultrasound gives you a lot of indication about correction. While you're assessing a child, you also get a lot of information about crosstalk and the use of other muscles, which kids will do if they're trying to retrain muscles. We've talked about cystic fibrosis. This is just a case study of an interesting boy that I was asked to look at, who has a neurogenic bladder and bowel and significant leg weakness secondary to spinal sacral neuroblastoma at 14 months of age. He was never toilet trained. His bowel was well managed. He was on CICs and oxybutynin patches, but he was very, very wet and had very wet pull-ups. At age 10, he noted that he could actually stop the flow of urine when he was doing his CIC, and the rehab doctors wondered if pelvic floor training might make a difference. So I didn't know. So I used real-time ultrasound, and basically over the period of, I saw him 6 times over 6 months. He had no awareness of his pelvic floor initially, so this is a 10-year-old boy. Once he learned to do a correct contraction, he gradually I could see that he could actually hold the muscles a little better, and the pattern here is within what we would expect a normal physiological training patterns. At 3 months, he was still wet, and I told him to pull his finger out and try and exercise a bit harder, which he did. And by 5 months, he actually had a marked improvement in his daytime wetting, and it's consistent with his pelvic floor function improving in terms of his ability to contract and hold. He's strengthening. He got out of pull-ups. He was able to wear underwear. He wasn't completely dry. He uses a panty liner, and but his pelvic floor capabilities improved with the strengthening training program. Neuromodulation is the last thing I wanted to speak about, and there's a growing body of evidence around this. And Janet Chase, Wendy Bauer actually did one of the first trials on TENS for children with overactive bladder. So it's neuromodulation is therapy that reduces symptoms or restores LUTs and function by alteration and modulation of nerve activity through central and or peripheral electrical stimulation or chemical agents to targeted sites. I'm just talking about simple things that are non-invasive. Again, I'm not talking about Botox or needle neuromodulation. I'm just talking about parasacral TENS, which is what we're doing in the clinic and which is what the evidence basis is around. So basically, there's 2 systematic reviews. It's probably time to write another one, showing a lot of favourable results for children with refractory overactive bladder. Some of the Brazilians use it as first-line therapy, but most clinics will use it as adjunctive therapy. The research, there's a lot of papers, but basically it's used anytime from 3 times a week for half an hour up to 2 hours a day. I'm encouraging families that can actually bother to use it to put it on for an hour a day, and the children control the intensity, and it's put on sticky electrodes parasacrally. There's one RCT looking at TENS versus oxybutynin and showing that it is as effective as oxybutynin. The TENS group had no side effects, whereas the oxybutynin group did. It does stimulate the bowel, and there's a recent paper looking at TENS showing that it actually stimulates rectal activity in children with overactive bladder. It stimulates it acutely. We don't know whether it stimulates it long term. There is one interesting study also looking at a group of children with TENS where they did urodynamics, and over about a period of 7 to 8 weeks there was a very gradual change in urodynamic parameters. So we don't know how it works, but for the right children it does, and we need more RCTs to actually define the population that it benefits most. Interferential therapy, which Patrina mentioned before, the trial was originally done again by Janet Chase, a physio. That's in Melbourne. All the research is out of Melbourne. It's a really promising new therapy. It's adjunctive treatment, different type of current. You need to use it for children with proven slow transit, and you basically create an interference, a current that increases transit time. That's the end results. The trials that they've done, though, is really quite interesting. And we've used it with some children as part of their bowel program with good results. But basically, they're getting improvement in soiling, perception of call to stool after about 8 weeks to 3 months, and an improvement at 3-year follow-up. So there's quite a large body of work there. And there are now portable treatments. I won't tell you about Benny. There's a few resources that are interesting. CFA have Pelvic Floor First website, which is for children that actually need pelvic floor strengthening. It's more adult stuff, but for your adolescents it's good. And the One Step at a Time, the Parent's Guide to Toilet Skills for Children with Special Needs, it's been really useful for some parents with children with special needs for toileting.